All right. Hello, everyone, and welcome to today's Zoom webinar on lessons learned, state actions, and advocacy to address malnutrition. I am Laura Borth, your moderator for today. I'm a policy associate with Defeat Malnutrition Today. And today we have two panelists, Brittany Woodbury, who will be discussing actions in Utah, and Matthew Smith, who will be discussing actions in Texas. So just to give you a little background on today's panelists, Brittany attended Brigham Young University in Provo, Utah, graduating with a bachelor's degree in dietetics with a minor in gerontology in 2021. She will be finishing her master's in dietetics and dietetic internship program at BYU this month, and will be taking the RD exam soon to become a registered dietitian. Her presentation focuses on the white paper she completed as her master's project on the state of malnutrition in Utah. She's from Colorado and just moved to Kentucky. She loves to ski and play pickleball. And Dr. Matthew Lee Smith is an associate professor in the Texas A&M School of Public Health in College Station, Texas. As an evaluator and interventionist, his research addresses health risk across the life course, chronic disease management, and the dissemination of evidence-based solutions for older adults. His translational work bridges research and practice issues across the healthcare sector, aging services network, and public health system. So feel free to ask questions throughout both of these presentations using either the Q&A or the chat. And I will save most of the questions for after each presentation. So with that, Brittany, take it away.
Thank you so much. All right, so like Laura mentioned, I will be discussing my project conducted on malnutrition in Utah. To begin, I will just introduce a little bit about my project. This project came about from the Utah Malnutrition Advocacy Task Force, or UMAT. They observed that a white paper on malnutrition had been created by numerous other states and determined that Utah needed something similar. Thus, the creation of a white paper was needed to evaluate current practices regarding malnutrition in Utah and provide action items moving forward. The white paper was intended to be distributed to healthcare professionals and policymakers. However, in the future, it could potentially go to the general public. This project was completed through an in-depth literature review, then semi-structured interviews, which I conducted with healthcare professionals, each specializing in different areas regarding malnutrition. Some examples were pediatrics, geriatrics, rural areas, and others, followed by many drafts and expert reviews from the UMAT team along the way. Just a little background information about malnutrition itself. Malnutrition is a prevalent issue around the world, including the state of Utah. It may result in stunting, wasting, developmental delays, weight loss, and nutrient deficiencies. Malnutrition refers to both under and overnutrition. The current prevalence of undernutrition worldwide is 9.9%. That was determined in 2020. And overnourishment in Utah adults is very prevalent, with 33.4% of Utah adults in the overweight BMI category and 29% in the obese category. Overnourishment is a form of malnutrition due to the imbalance of nutrients, leading to excess weight and higher potential for micronutrient deficiencies. So from the literature review, interviews, and expert review along the way, we determine what the problem is for the state of Utah and then the action items that need to be taken. These are the main problems that we determine Utah is facing at this time. First are the causes of malnutrition, which are illness or non-illness related. The illness-related causes may be acute and chronic illness, inflammation, and the obesity malnutrition paradox, meaning that under and overnutrition coexist in the same communities or individuals. Non-illness causes of malnutrition may be economic instability, food insecurity, and social and community environment, including food deserts and racial and ethnic minority groups. The next problem we determined were the financial costs associated with malnutrition. Hospitalized malnourished patients typically accrue 34% higher costs compared to non-malnourished patients. In 2016, which is the most recent data for Utah, the estimated annual direct medical costs that could be attributed to malnutrition for the state of Utah was $108,943,000, or $36 per capita. The next problem identified was the lack of standardized screening and diagnostic tools within the state. The lack of standardization makes it more difficult to accurately track the prevalence of malnutrition, and we would like to increase consistency across the state. The last problem identified was simply the lack of awareness of malnutrition among the general public. So from the literature, interviews, and these problems identified, we came up with 6 strategic priorities to prevent and treat malnutrition. And these are those 6 priorities. The first is to increase awareness, prevent malnutrition in the community, prevent malnutrition within healthcare, adopt standard procedures for the screening and diagnosis of malnutrition, treat malnutrition, and improve coordination. Each priority has subcategories of specific recommendations, which I will now be going over. Priority 1 is to increase awareness of the prevalence and challenges of malnutrition. And the first way to do so is to communicate this prevalence of malnutrition to policymakers. Those working with nutrition daily are aware of the incidence of malnutrition. However, many in positions to actually instigate change and affect funding and other tactics to prevent and treat malnutrition may not be as aware. Communicating information about malnutrition to policymakers increases awareness and encourages these officials to act on the recommendations that we have provided within the white paper. State legislators can make very significant differences when it comes to implementing programs and funding. The next way is to increase awareness of malnutrition among the general population. The general population also needs to be aware of malnutrition. Many Utahns may still believe that malnutrition only happens within third world countries. Increasing awareness for Utah can improve participation in community programs, support for public policies regarding malnutrition, and increase recognition of the early signs of malnutrition in their loved ones. The second strategic priority is to prevent malnutrition within the community. And the first way to do so is to promote legislation to maintain or increase funding of community programs. Community programs that assist families in purchasing food, obtaining food decrease the risk of malnutrition. Programs include WIC, Early Learning Essentials, SNAP, Meals on Wheels, different senior centers, farmers market programs, food banks, soup kitchens, as well as population and faith-based organizations may decrease the risk of malnutrition by providing food for their participants. Legislation that maintains or increases funding for these programs should be promoted and supported. Next is to provide school and community-based nutrition education. Schools play a very important role in helping children establish healthy eating behavior, yet nutrition education is severely lacking within schools. Community programs such as Extension Services, SNAP, WIC, and others already teach these types of skills, and expansion of these programs in the community and schools will provide an opportunity for learning and hopefully malnutrition prevention. Next is to expand free school meals and programs. School breakfast and lunch programs are currently available throughout the state. Some districts also provide summer feeding programs. During the COVID pandemic, free meals were extended to all students. However, this program is coming to an end. Continuing to fund free meals for all students, along with funding summer feeding programs for all the districts, can provide nutrient-dense food for Utah's children and reduce the risk of malnutrition. Continuing with priority 2 is to ensure equitable access to food through policy initiatives. Local governments should consider strategies to expand the availability of nutritious and affordable foods to all areas. Limiting taxation on food products or tax breaks or property incentives for grocery store chains to build in minority low-income areas could increase this access. Next is to support breastfeeding. Breastfeeding plays an important role in preventing childhood malnutrition. Legislation focused on supporting breastfeeding and maternal health, including supplying iron and folic acid to pregnant women, may prevent malnutrition. In addition, supporting actions to encourage breastfeeding for working mothers is needed. Develop eating habits and family mealtime dynamics. Establishing healthy eating habits early on in life can prevent malnutrition. When children are stressed during mealtimes, they tend to eat less, which increases their risk for malnutrition if this becomes a consistent pattern. School and community-based education, as we discussed previously, are ways to support and encourage healthy family eating dynamics. Strategic priority 3 is to prevent malnutrition within the healthcare system. And the first way to do so is to identify risk factors and high-risk populations. Identifying these risk factors early on can assist healthcare workers in targeting high-risk groups for intervention to prevent malnutrition. People with chronic conditions are at higher risk for malnutrition. To reduce the incidence of malnutrition, anyone with a chronic condition should be screened for malnutrition on a consistent and frequent basis. Some suggestions include screening during annual exams, doctor's appointments, or during community program participation. Next is to adopt the room service model of service. The room service model of food delivery allows patients the flexibility to order meals at the time of day and frequency that they would prefer. Patients are more likely to consume adequate calories when they have the flexibility of ordering what they would like instead of receiving meals at structured times. Many hospitals across the state already use this form of service, and they should be encouraged. However, an important piece to note is that the hospital should consider their patient population, and in some instances, using a hybrid model of service may be more beneficial, especially if there's a high proportion of elderly patients. They may prefer someone to come to their room and visit them and help them order instead of them calling with the room service model. So we will evaluate the patients within the hospital to determine. Continuing with priority 3 is to ensure adequate protein intake. Sufficient calorie and protein intake is the foundation of preventing and treating malnutrition. Hospitals should privilege dietitians to order high protein supplements and therapeutic diets to provide patients with the calories and protein that they need. Policies should be put in place to assure that energy and protein supplements will also be covered by their insurance. Next is to provide and fund post-discharge meals for high-risk patients. This is an excellent way to transition patients from their hospital stay to home. Funding sources do need to be put in place for these feeding programs, including the cost of meals and home follow-up by a registered dietitian. Funding sources may include hospitals, Medicare, Medicaid, and private insurance to reduce malnutrition-related readmission costs. Next is implementing fall prevention programs. Falling increases the risk of malnutrition for older adults due to the necessary recovery time and the potential health decline afterwards. Occupational and physical therapists, dietitians, and other providers are key members of this program. Senior centers, in-home care, and nursing homes are great points of contact to implement these types of programs. Strategic priority 4 is to adopt standard procedures for the screening and diagnosis of malnutrition. There are many screening and diagnosis tools available. Consistent and standardized use of a screening and diagnosis tool across the state of Utah can help the identification of malnutrition and better determine the impact of malnutrition within the state. With this data, prevention and treatment strategies can be put in place to high-risk areas. These are recommended for use within the state of Utah. However, I would like to emphasize that for children, there are currently no validated screening tools. These are just options that were brought up during the interview process consistently. So other tools may also be considered. These are the ones we may recommend at this time. Hopefully in the future, as we validate screening tools, we can solidify these recommendations. So for screening tools within the community, we recommend NutriSet for children, MST for adults, and Screen2 for older adults. And then within healthcare, we recommend Stamp Tool for children, MST for adults, and MST for older adults. And then for diagnostic tools, we recommend the Academy and Aspen indicators to diagnose malnutrition, AAIM, for children, adults, and older adults. Continuing with priority 4 is to expand reimbursement. An estimated 30 to 50% of patients are malnourished, but roughly only 8% of patients are diagnosed with malnutrition and subsequently coded and billed to insurance. This discrepancy greatly underestimates the actual costs and limits resources for prevention and treatment. More work needs to be done to assure that patients, clients, and community members are assessed for malnutrition and that this is translated into reimbursable billing codes. Adding dietitians as providers that can provide a diagnosis for malnutrition and bill for the treatment can improve identification and resources for this treatment. Next is to add malnutrition to the active problem list. Dietitians should coordinate with physicians and other licensed providers to assure that the nutrition diagnosis and malnutrition are documented in the patient's active problem lists within their medical record. Documenting malnutrition as an active problem will make it a priority throughout the patient encounters. And as well as every time the patient is seen by a healthcare provider, members of the team will include treatment of malnutrition within their care plan. Priority 5 is to treat malnutrition. And the first way to do that is identify any underlying cause of malnutrition that may exist. Malnutrition can be caused by many different things, and if a medical issue such as celiac, allergies, acute disease, or other malabsorptive issue are already in place, then those should be treated. Most chronic organ diseases are associated with a chronic, mild, or moderate inflammation, which increases the risk for malnutrition. And careful control of these chronic diseases can reduce the risk of malnutrition for that patient. Next is to increase calories and protein. The most basic form of malnutrition treatment is providing sufficient calories, protein, and other nutrients. And this may be done through oral supplements, nutrition support, concentrating infant formula, and power packing foods. Next is to improve Medicaid coverage for partial nutrition support. Medicaid coverage for partial nutrition support by enteral tube feeding is more difficult to obtain compared to coverage for full tube feedings. Medicaid coverage for partial feedings is often denied. And when it is denied, physicians and other practitioners must make an appeal, which leads to frustration and concern for the patient or client. Rules and guidelines for approving partial enteral feeds for insurance coverage need to be defined and adopted. Lastly, strategic priority 6 is to improve coordination of community programs, healthcare systems, and policies. And the first way to do that is to train a larger amount of people to screen. Screening for malnutrition leads to intervention and identifies high-risk populations, so prevention strategies can be put in place. Training a broad range of professionals to conduct this malnutrition screening assures that malnutrition will be identified and treated. Professionals including nurses, diet techs, pharmacy techs, physical therapy aides, occupational therapy aides, home health aides, medical assistants, and many more can be trained to screen. Next is to work with faith and community groups to increase screening. Utah has a well-known culture of caring for others. There are strong faith-based networks that already exist that assist people with housing, food, and social programs. This culture provides an opportunity to utilize faith and community groups in malnutrition screening efforts and stretch the resources, particularly to rural areas. Next is to allocate resources to diverse social and community areas. The geography of the state of Utah has concentrated metro areas coupled with very vast rural areas outside itself, and it makes it very difficult to assure that the entire population is screened, diagnosed, and treated for malnutrition. Rural areas outside these key metro areas may be isolated with limited access to healthcare, supermarkets, and affordable foods. Policies that assure resources are allocated to all areas within the state can make the identification and treatment of malnutrition more equitable. And then lastly, improve coordination of care. Coordination of care is essential to prevent and treat malnutrition. Clear communication about malnutrition screening or diagnosis between organizations is needed. Shared communication will assist providers in understanding the patient's status, save time in diagnosis, and can improve patient outcomes with continued care. Thank you very much, and that concludes my presentation for this time.
All right, thanks, Brittany. Before we go on to the next presentation, this is an opportunity for anybody to ask Brittany questions, and otherwise we will have a time at the end for Q&A. So you can write your questions in the chat and in the Q&A. All right, seeing no immediate questions, we will continue on to Dr. Matthew Smith.
Hello, everyone. Let me get this all set up. Hi, everyone. Thank you so much. That was wonderful, Brittany. I mean, so much of what I'm going to talk about really dovetails with all of those strategic priorities and all of those actions. What I'm actually going to speak more about today is a practical tool and a strategy of trying to identify risk, raise awareness, unify communities, and really have some form of dialogue that we can really start to advocate and create action. So what I'm going to talk about is a county level characteristic associated with malnutrition related deaths in the state of Texas. And really what this came about, like Brittany said, is that we were interested in doing a state of the state in Texas, understanding what is happening, what is going well. And to start that process, we actually took a more objective approach, and that's really what I'm going to speak about. So as Brittany kind of mentioned, naturally, when we talk about malnutrition, we understand that it's not just underconsumption, there's also overconsumption, and it's really an imbalance. And because malnutrition is caused by so many factors of life, we really need to think of a holistic approach when we identify it, when we address it, and we really think about our communities to be able to better meet the needs of our older adults. And that goes across so many different factors because the consequences are so dire. We know that there are many different consequences from malnutrition, ranging from health, loss of independence, and of course, healthcare costs, which we naturally know are very important, but ultimately, it can contribute to death. And that's what we're actually going to focus on, is the most extreme cases of malnutrition where it actually resulted in malnutrition related death. So with that, there's certainly a need for multi-level efforts and initiatives that we can identify risk, but also try to have those linkages to community-based programs, services, etc., while also understanding the root causes of these issues so that we can start to address them more upstream. Now, when we think about our health and especially malnutrition, it's really a really mixed combination of who we are So our genetics, our demographics, our personal attributes. It's also what we do, the way we live, our behaviors, the things we do and don't do, and of course, where we live, because environment has a lot to do with what we do and the access we have to certain types of programs and services. And so in recent years, there's been a huge emphasis to better understand health and place, those built environments, and the geography, because really that built environment, that physical environment is so important when we think about how it shapes the social environment. But in addition to that, especially in rural communities, when we think about the infrastructure of a community, how dispersed or spread out the different community, clinical, or food-related services organizations are, the way that they actually interact with one another to have more continuity of care, making sure that we reach all of those individuals who need services and need resources. That is a lot of times driven by those physical and built environments. And oftentimes it can truly diminish the availability, the accessibility, and the affordability of high quality resources, whatever they be. And so really what we're looking to do is identify a bit more about the communities in terms of their risks so that we can identify what they need and how best to accomplish those goals, solutions, partnerships, and services. So with that, what we did was set out to create a study. And with that, we did this pre-COVID, because as Brittany mentioned also, the most available data is actually pre-COVID. There are some projections from 2021 that are coming out and things that are there, but the actual data available, especially at this time, was pre-COVID. But what we really aimed to do was identify the prevalence of older adult malnutrition death in Texas, examine those county level characteristics associated with crude malnutrition death rates, and then of course describe those assets or opportunities to address and improve malnutrition among older Texans. So to do this, we used risk and asset mapping. And this is something that I use oftentimes in communities because it really helps us to better identify and visualize risk so that we can then start thinking about our issues of equity, inclusion, and certain types of disparities. And so what we do is we take multiple sources of data, we layer them on top of each other in a map, and that helps us to identify areas of high risk, those hotspot areas. And that helps us to identify also what we call those bright spots. So those areas that are actually doing quite well. They're well performing. So in addition to identifying high risk, we can also see those more resilient communities and ultimately start to shape some ideas, some solutions for targeted efforts in terms of our programs, resources, and services, and of course, funding allocation. So to do this, we identified multiple sources of data. And you can see from CDC, from the, let's see, from the Department of Agriculture, from the census, we really took a lot of different sources of federal data that were available for Texas in the same timeline, and were able to identify rates of malnutrition death. We were able to look at rurality and service provision, as well as the community composition in terms of the sociodemographics, poverty, the proportion of those residents receiving SNAP benefits, and overall food access within a certain mileage. So I'll talk a little bit more about that. But really what we were able to do was, you know, Texas is a huge state. So there are 254 counties in the state of Texas. So what we were able to do was actually group them based on their crude malnutrition death rates into 3 groups. So that way there's about 84, 85 counties in each one of these 3 groups. And they're really ranked based on those counties that have the lowest level of malnutrition death, the medium, and the high. And that way we can start to talk about counties in these rankings based on the distribution. And then of course we used some mapping, some GIS mapping, to be able to visualize what we were learning in terms of all of these data sources. But we also, it's not just about risk mapping, we wanted to show the assets. We wanted to show some of the food stores, the area agencies on aging, and even some of the food pantries, especially those that were in terms of the Meals on Wheels food pantries. So in the state of the state and trying to better understand what was happening here in the state of Texas, we identified that pre-COVID, there were 25,000 or more malnutrition related deaths among our older adults. And when you look at each of these counties, we can see that the average number of deaths was almost 100 per county, but that ranged and it varied. Some counties had 0. Some counties, especially those that are larger, more metropolitan, larger communities, certainly had more, ranging all the way up to about 3,800 malnutrition deaths. And this is just in 1 year. Now, when we think about the crude rate of death, we really are thinking about the number of deaths per 100,000. So the crude death rate in Texas was 66 deaths per every 100,000 older Texans aged 65 and older. And that crude rate, again, varied because some had 0, but some had upwards of 415 malnutrition deaths per every 100 residents over age 65. Now, again, Texas is large, so that 254 counties, when we look at those and we try to understand a little bit more about what they are and how they're classified, we see that 68% were classified as non-metropolitan or more rural. And of those also, over 80% were a health provider shortage area, meaning that the proportion of health providers relative to the number of residents meant that the area did not have enough. It was a shortage area in the county. Well, that says a lot about the state for a lot of opportunity. Now, about 1/3 of the households in Texas with those who were 60 and older received SNAP benefits. But when we think about those individuals 65 and older, 62% had low access to healthy foods within 1 mile of their residence, and 20% had low access to healthy foods within 10 miles of their residence. So again, describing so much more of what's happening in this area. When we performed our analysis, again, we wanted to look to see about what is it about those high-risk areas, those tertiles that we created, those groups from low, medium, and high risk in terms of the crude death rate. And what we found were some risk and protective factors. The risk factors, of course, when we thought about those counties in the higher risk group, those counties were more likely to be those non-metro or rural counties. And those counties also had larger proportions of their residents who did not have a high school education or equivalent. They had more households in poverty. And they also had more residents age 65 and older who had low access to food within those 10 miles, confirming a lot of what we know. But there were also some protective factors that we identified. And those protective factors were the counties that were in that lowest malnutrition death rate. Those counties in that group had larger proportions of adults who were age 85 and older, those oldest old, but also larger proportions of Black, African-American residents and Hispanic residents. Again, showing protective factors. Now, this table represents what I just spoke about, and the green shows some of those protective factors, the red showing some of those risk factors. But we took all of this information together and were able to create some visualization. And that's really what we were looking to do, is to take this evidence, be able to describe it more objectively, but now let's map it. So what you can see is that the color of blue shading is actually based on those tertiles, those groups from low, medium, and high risk of malnutrition related death. And so the darker are the more high risk areas. But we also, and this is the beauty of mapping, we also were able to put multiple more layers on top. Now, we couldn't put every layer on top because it just gets so very messy. But oftentimes we zoom in, we focus on certain service areas or certain clusters of counties to be able to better understand what's happening, depending on the service area of a, managed care organization or any other type of AAA, whatever it be. And so here what we did is we actually overlaid the counties that had 50% or more of the residents 65 and older who had low access to food stores. And so that's what that hash mark, that shading is, are those counties where more than half of the residents age 65 and older had low access to food. And then we also wanted to go ahead and we grabbed a lot of other types of data sets to be able to map those food stores, the area agencies on aging, those Meals on Wheels food banks. And so we pepper that on top. And so with this is a very valuable tool to go ahead and bring together communities to have that collective conversation where we can now go in and look at the context, the history, and even some of the assets in these communities. It's a great starting point to start the conversation across those clinical and community lines, engaging the community residents themselves, the faith-based organization, residential facilities, but those policy and decision makers as well. So we utilize this tool in action-oriented ways to be able to make that happen. So what it is that we learned, of course, was that the socioeconomic drivers of malnutrition were confirmed. And this is something that we know, and that much of those death rates in Texas are based on those socioeconomic drivers. But we also saw so many protective qualities within these counties that can maybe show resilience or their unique ability to protect their older adults from malnutrition-related death. So when we think about, again, those counties who had larger proportions of residents 85 and older, Black or African American or Hispanic, we saw that those communities had more protective qualities. This could be because of the cultural regard for older generations, or even more intergenerational homes, and thinking about the composition of homes and the supports that older adults receive. It could also be that these counties have more unique programs and services relative to their other counterparts that don't necessarily have this county level composition, and some of the partnerships that exist. So when we really start digging into some of the different organizations, the policies, the healthcare related organizations, we really can start to dig in and understand a bit more in context with those of the community to see what's happening and what we can borrow from these well-performing communities and hopefully roll them out in other communities that aren't performing as well. Capitalize on the strengths. This is something that is extremely important and an opportunity for us all, but it starts with understanding what the risk is. Now, again, this is something that we were able to do pre-COVID, but when we regularly update this, and we're currently doing it now, looking at not only malnutrition related death, but also just higher level county rates of food insecurity, and over a dozen other indicators like poverty, education, access to transportation or ownership of a car, so many of these different aspects, we can better learn what's happening in our communities so that we can start to introduce those programs and really start to blend the clinical, the community, and the policymakers together. Now, there are wonderful resources out there, and one of them, of course, is the Administration for Community Living. They have great assets on their website, as well as the National Council on Aging. But one I really want to go ahead and highlight, because it is homegrown and it's a program that I've worked with for a long time, is the Texercise program. So Texas Human and Health Services created Texercise many years ago, and it is a program about nutrition and physical activity. And so that's what it primarily focuses on. But I commend the Texas Health and Human Services for doing this by understanding the risk of malnutrition and some of the other needs. They were able to evolve and create new programs from Texercise, like Texercise Prevents Malnutrition in Older Texans, or the Texercise Nourish program. So a lot of homegrown Texas-based efforts happening here. And I really hope you look at some of these resources and see what it is that they're doing, because it's quite vast. And Texas is a big and complex state. as you can imagine, but so many other opportunities. I do want to highlight that this is naturally a collaborative, as so many things are, and that actually this study and more details about it have been published in the Journal of Nutrition, Health, and Aging. So we can go ahead and provide that to you all as well. But I thank you so much and appreciate it.
All right. Thank you for that presentation. I learned a lot, even I was taking notes. So we have a few questions, specific questions to start for both Brittany and Matthew. So Brittany, going back to your presentation, there's a question of if you looked at malnutrition intervention coverage data among private insurers, like, you spoke to Medicaid barriers for partial nutrition support, but did you find anything with private insurers?
That is a great question. I would say we mainly looked at Medicaid with the action item to provide support for enteral coverage, but some of the strategic priorities also include improving coverage with private insurances. So while I don't have specific numbers, that was a theme that came up through the interviews. Is sometimes it's difficult to get coverage for supplements or different interventions that the patients or clients may need, and that would be private or Medicaid, Medicare coverage. So I don't have the specifics, but yes, it is difficult to obtain coverage for all forms, I would say.
Okay, thanks. And then we have a specific question for Dr. Smith. How was it determined that death was caused by malnutrition and not another factor? I'm sure you've heard this before.
Absolutely, and we talk about this in so much detail. So this was actually from the CDC Wonder system. Therefore, it is fed up from counties to states into the federal repository. And so with that, that means that malnutrition death was listed as a cause, maybe not the cause or the primary cause of death. But at the same time, what we need to understand, of course, is that many of the older adults who have multiple chronic conditions, there are many different situations occurring. We don't necessarily know, and we weren't able to capture what other conditions they had. For example, was it based on individuals with cancer, for example, or other individuals who literally were uninsured, underinsured, and etc. We just know what the rates were per county because it's rolled up. So there are many different caveats you can place on this.
Okay, thanks. Let's see. We also have a question, someone from New Mexico saying that a majority of their communities are Hispanic and Indigenous. And how could access to culture appropriately foods decrease malnutrition for individuals and communities? So I guess either of you, you want to answer that question.
I'll just say something ever so quickly and then I'll let Brittany answer. But one of the best ways, of course, is to make sure that these populations are involved in every single aspect, from planning to execution to evaluation, and it becomes cyclical. So what we really want to understand is, what is it that would reach this population in a way that's meaningful? What's appropriate? What can they access? And what is it they would want to see? We do this a lot in terms of trying to identify, kind of as Brittany did with her interviews, individuals who serve these populations and individuals of these populations, so that we can better understand and teach the test, because the last thing you want to do is introduce something that is not going to be adhered to. It's a squanderance of time and effort, and of course, health.
Yes, I would just echo what Dr. Smith said. If someone is surrounded by healthy foods, but it's not something that they're familiar with culturally, then that really won't help them in the way that it might help someone else. So while we're addressing food deserts and access to food, we also need to keep in mind the culture that surrounds the area that we're trying to address, and support them with foods that would be familiar to them and help them form their own healthy plate that is familiar and comforting to them. Absolutely.
And then I have a question that I think both of you can contribute to. So Brittany, you had to identify the right people to interview to get the data that you needed. And Matthew spoke to having folks find each other to start these like multi-level conversations and initiatives. So for people in other states, like how do you go about finding the people that you should talk to?
I can start for that one. I feel very lucky for Utah. We had this advocacy malnutrition task force already in place, and that's who I was working with to conduct this program. But for someone who may be in a state that doesn't have that sort of task force, I think you can still work through networks to determine who you need to discuss. So for me, I communicated with someone who was prevalent in rural areas. So I found that person through recommendation through UMAT, someone that I knew, and they said, hey, I know a dietitian. She works down near St. George and she's very familiar with rural area. And then I made a connection with the geriatric population just through my gerontology experience. And she had really great ideas for that population. So I think just talking to people and determining who are the kind of stakeholders in the state who can help you out to learn more about what your state is in need of.
I echo all of that. I think that was, really, it covered most of it, Brittany. I think part of it also comes down to, in looking at your area, are you attempting to address everything in your state, or is there a region, or is it your county, or is it your organization? So depending on the difference of what is it that you're trying to address and how broad the scope is, that will really guide who you engage. So when we think about in a certain community, there's the clinical sector or the healthcare sector, there's the public health system, there's the aging services network. So who are the organizations serving these individuals, and who are the individuals who are accessing and not accessing these resources? Then we can go ahead and start to identify who to engage based on who's actually accessing and who's not, and try to use those different types of perspectives to help blend or guide leverage points. And that's really what we're looking for, those leverage points, that continuity of care, those multiple touch points, like Brittany said, where everybody needs to be doing the screening. Everybody, every setting is an opportunity for intervention. So there's just so much to be done.
Yeah, great. So another question from the Q&A. Do you think policymakers in your states recognize the link between malnutrition and healthcare outcomes and costs?
Of course they do.
Well, that's good.
Do they know the magnitude of it? Do they have all the solutions that are practical and cost effective to be able to implement in each of those settings? That's interesting. I mean, I think that's kind of it is, so many of us know what the problem is, but the question is, how do we address it and do so effectively? And how do we reach the broad number of residents who really need it?
And I'll just add, one of our priorities is to echo this importance to policymakers so that we can work with them to decrease the incidence and risk from malnutrition. And I think what's really valuable when discussing these issues with policymakers is solid information and numbers or testimonials. If we don't have the data available, just any sort of evidence that we can use to describe how important this issue is. We can be the experts on the area, and we need to communicate that in a way that is convincing and important to the policymakers so we can work together.
Great. And at least Defeat Malnutrition today, we've made some toolkits for other states for state advocacy and federal advocacy as a resource. All right, so let's see. We have another question in the Q&A. speaking to those connections in the community, what recommendations do you have for large food banks to better connect with healthcare services to address the issue? Or even more broadly, like, how does one go about making that connection?
Brittany, I think you spoke to it quite wonderfully when you talked about some of the, shelf stable meals and some of the things that you recommended.
Yeah, I would also add doing and address the population that you're trying to serve with the food bank, kind of going back to the culturally appropriate foods. That can be one way to connect better with the community that you're working with and hopefully get more participation.
And I think, part of it is, and this is why we started with identifying some of the statistics and understanding a little bit more about the communities and why they have the issues they have, is that if you can identify some common pain points across these different sectors, and you understand that they're serving similar residents in similar spaces, and that they're all carrying the burden, the natural conversations of how do we collaborate? How do we share resources? How do we have more seamless referrals or connection points? Everyone starts to have these conversations a little more naturally. Now, are the logistics challenging? And are they actually going to be able to roll out? Do you have to pilot something really small first, see if it works before you can really grow and expand? But at least it's a starting point. So a lot of times data is power. Raise that awareness and start the conversations from people with the same lens.
Great. And then a question for both of you. Was there anything that was surprising in terms of like challenges to conducting these studies, or something was, easier than you expected? Some tips and encouragements for other people who want to do the same thing.
As it was mentioned, I did this project for my master's thesis or main project, and it was quite overwhelming to first think, okay, I'm going to evaluate the entire state of Utah. I haven't even been to all of Utah. I haven't been to all those parts. I'm not an expert in all these different life stages that we wanted to evaluate. And so I do think at the start it can be quite overwhelming, but what I was surprised and very grateful for was working with other professionals who are experts in that area. I don't have to be the expert with geriatric malnutrition because there's someone in the state who already knows and is very passionate about that. So if I can just find the right person to connect with, then it made this project much more doable and feasible. And it's very rewarding to see it all come together and use everyone's expertise in a summative format.
Yeah, and I certainly agree with that. I think, part of it really comes down to, just being able to have, in our case, the most recent data. And if you're going to do something more secondarily, the problem is once it rolls up from any organization to a county, to a state, to the federal, well, now all of a sudden, unfortunately, so much time has passed, you're really looking at the past. And for us, another challenge was more about not just the most recent data, but also we elected to focus on the end result, death, the most extreme case possible. Well, if that's really, very eye-opening to everybody, think about the amount of malnutrition that's existing, not just those who died from it. So it's certainly a challenge because identifying food insecurity is somewhat challenging, obviously, in communities, and trying to identify who it is that can benefit most in all cases.
Great. Well, we just have a few minutes left. So do either of you have any parting thoughts? And as you are thinking of that, I'm going to share my screen so that everybody can see the contacts. If you would like to continue discussion with Brittany or Matthew, here's their emails. So if either of you have any parting thoughts or exciting new things in the horizon.
I think it's just great to be here with everyone and see all the participants. And it's really wonderful that there's a community of people, all across the US who care about malnutrition. And these are great steps to take to improve identification and treatment throughout the nation.
Yes, and we are certainly continuing our initiatives. We're actually looking at well over a dozen of these different health risk factors and trying to look at the various communities and kind of better understand food culture, or at least the risk factors, the bright spots, and try to think through how we can facilitate partnerships. So we're ready for new data and really starting to get into that. But what we're doing at this high level is so valuable when combined with what Brittany and her team did, because that's really getting to the root of it and identifying concrete action and really concrete solutions that people can grab a hold of and integrate into their organizations and communities. So I commend you, Brittany, for all the work you've done in Utah. Really wonderful.
Yes, thank you both for your presentations. And thank you to all the participants. We had a really great showing for this webinar, and the information will be available in a couple of days to everyone. So with that, everyone have a good Monday afternoon. Thank you. Bye, everyone.